Again, thank you for inviting me. And the topic today is biomarkers and medical oncology treatment of HCC. And pay attention to this. I make it a December 6, 2020 edition because it could change tomorrow. And it has been changed very quickly for the last few years. I have nothing to disclose. Objective is to present to everybody the new trend in biomarkers in HCC and rapid changing and highly competitive fields of HCC treatment is amazing. It's a worldwide competition. Globally, the liver cancer is number 4 cancer cause of death. And the 5 of the top 10 global cancer deaths were all from GI cancer. It's quite amazing how GI caused a lot of death. Biomarkers are something that we can measure as an indicator for the presence of disease, and ideally also used to evaluate the status of disease to treatment response, progression, and also hopefully be able to use to monitor recurrence for future treatment decisions. So where are we with the biomarker in HCC? And this is purely from medical oncology points. Certain terminology and also current trends of new biomarker. One is circulating tumor cells, the other one is circulating tumor DNA, and liquid biopsy. And at many times, circulating tumor DNA almost equal to liquid biopsy. There's small quantity of DNA, very short fragments, and depends on the panel design and also the platform they use. For example, next-gen sequencing that we heard so much is not one test, it's not one platform. They're tagged Apricon, and they're also Iron Torrent. They're all different platforms of next-gen sequencing used by different companies. Which one is better than the other? We do not know. And they're also methylation sequencing, and also based on different platforms. So circulating DNA is now one test. The concept is very simple. Tumor cell can get into the circulation, and the fragments of DNA, once cell dies, they can leak into the circulation as well. But keep in mind, normal cells can also shed their DNA into circulation once they die as well. This is circulating tumor cells. The first was approved by FDA in 2004 called the cell search. And the green box here represents the research on HCC done with this technology. But unfortunately, the cell search is based on the EpCAM that was expressed on malignant epithelial cells, but only about 20% of HCC has EpCAM expression, and hence the result of positive identification rate with the cell search is over the board. There is another FDA-approved cell search or tumor cell we can order, but that's only specific for prostate cancer. But in reality, since FDA approval in 2004 to now, 16 years, I myself and to my knowledge, none of my colleagues has ordered any circulating tumor cell tests. So I think the future of this circulating tumor cells is kind of questionable. The more promising will be the genetic testing or DNA testing. But before we go there, I'd like to present very quickly our gene of a twin study. Our genes are not static. Epigenetic change equal to DNA methylation. The sequencing was not changed, but the gene can get turned on and turned off because of epigenetic change. Identical twins are born minutes apart, but they do not die minutes apart. And they do not die from the same disease. It's all because of epigenetic change. This is a study that showed, as an example, 3-year-old versus 50 years old. Beginning at 3 years old, they have very few epigenetic variants. But then by the time they reach 50, they could be morphologically look identical, but genetically, they're pretty much two different persons. And the effects of epigenetic change is global. All 23 pairs of chromosomes can be affected, and hence epigenetic change that when we want to use as a test has to be extensive next-gen sequencing-based platform. And how does this apply to the disease? One of the presentations in AASLD this year is from a company they call a liver test based on methylation panel to detect HCC. The panel is based on their initial publication back in 2017. They have more than 1,000 HCC tissue sample compared to normal control on the leukocyte. And then they come up with the HCC specific methylation panel to detect the presence or absence of HCC. And this year in November, they present their validation test, and it seems to indicate their test is better than alpha-fetoprotein or ultrasound to detect the presence of early stage HCC. If anybody pay attention to the news media, there's two trials. One's Pathfinder in United States, and there's a Gallery test will be open in UK early next year. They have more expanded ctDNA methylation panel to detect greater than 50 cancers, and HCC is included. All those require a lot of deep learning process through the artificial intelligence. It's nothing that we can look at the report and figure out whether it's positive or negative ourselves. But the problem with the methylation test and the way it's so difficult to say or conduct is this: it's a normal aging process. As the figure here show that methylation change accumulate with aging process. And there are actually several models here using DNA methylation clock to check how long we will live in any individuals. What specifically for us and of our interest is those disease-specific and cell-specific effects. I didn't find any data in related to HCC, but I do find one article published from Hong Kong, and that's their result. They check using PCR, looking at specific methylation markers on the normal versus breast tissues. And they noted that on the normal tissues, there are also some methylation change that you could find in tumor. Very similar to the cancer genome ELA data that's from the European and America. The normal and tumor cell does have some overlapping on the epigenetic change. Hence, for the epigenetic panel to be done, you have to check thousands, if not hundreds of thousands of locations. And it's not a test that we can do like sending out blood to know your alpha-fetoprotein level. It's truly based on deep learning and artificial intelligence. And hence, a validation test in patient normal subject is not enough. We need to have prospective trial to know if the DNA methylation panel really would be a good diagnostic test. How about routine DNA mutation? Can we use the genetic change in the DNA level base pair change to detect the presence of HCC? And this is one of the publication that has analyzed more than close to 1,300 HCC cases. Unfortunately, the mutation frequency in the HCC is, we cannot find one that's 100%. The most common one is telomere maintenance mutation, and only in about 54% of the HCC. That make it hard to come up with a circulating DNA as a test to detect the presence of HCC. And the published data from different researchers use some using different combinations of gene, some using one gene, and hence the result is also not applicable very easily from one trial to another. And that also talked to the difficulty of using circulating DNA to detect HCC. And the other conundrum we have is, we know the tumor progression is cumulative. If we detect somebody that has early mutations, can we really find something in the liver to treat? Do we know where it is? Say, telomere promoter mutation or DNA methylation, that we find some positive signal the patient may have HCC. Can we really know where it is, and how should we act on that? And we do not know yet. In normal persons, and this is one study published in Science of last year, the somatic mutation accumulate with aging. So it's not a surprise, skin, lung, and esophagus has the highest somatic mutation cumulatively, especially if you're older, age above 45. And can those mutations be detected we use circulating DNA or methylation panel as a screening tool in the normal individual and give a lot of false positive? We do not know. And the other publication came out April this year, and they, from the United Kingdom, they give two examples. One is 34-year-old lady, the other was 60-year-old. They look at uterus, the histology of uterus. They all look exactly normal. appearance by microscopic examination. But this 34-year-old lady actually has mutation in different foci of normal appearing uterus, more than this 60-year-old lady. So what should we tell this 34-year-old? Can we predict that she will have tumor development? Should we take out the uterus right now, or should we continue to observe? This is on the right-hand side here is a predictive modeling as to estimate when the mutation began to occur. And some of the potential tumor-driven mutations like KRAS, PIK3CA occur by age 10. We don't know that's for sure or not because it's modeling. But again, it argues, is it possible we may be picking up some false positive circulating DNA? It would relight it as a biomarker. This is one company from Denmark present their 16 unique somatic mutations. The company claimed they can identify more than 100 mutations in every single cancer patients on their tissues. And out of those multiple mutations, somatic mutation, they pick 16, they call the high rank mutation to come up with a unique panel, n equal to 1. So it cannot be translated to the other patient. And they did this on the subgroup of a patient that participated in the clinical trial using atezolizumab plus bevacizumab for HCC. And the interesting thing is before the treatment started, 96% has positive circulating DNA. On the patient that went into complete CR, 70% has negative circulating DNA, whereas the patient that not responding, they have 0% has negative circulating DNA. So indicate that circulating DNA may be a way to monitor response and potentially can be used to monitor if there's recurrent disease, especially in the group that has achieved complete remissions. This is very new data, but I'm going to use colon cancer as an example. This is a paper published last year from two groups, one Australia, one Johns Hopkins. On their previous publication, they showed that they can identify between 8 to more than 2,000 somatic mutations in colorectal cancer sample. Not like the other company who claim they can always identify 100, but they pick using their safe sequencing system to select a single mutation to come up with circulating DNA. But the result is quite promising or surprising. The patients that are negative on circulating DNA, their survival is much better than positive. And then if you have positive circulating DNA after surgery, but turn negative after chemotherapy, then your survival is better. Whereas if you have negative DNA after surgery, but turn positive, your survival drop very rapidly. And so this is the hope that the company or many commercial research lab try to see if this kind of circulating DNA test could be used in HCC to follow response and monitor disease recurrence. Can they replace the other tumor marker? We do not know. So the ctDNA and the circulating tumor cell, they're not really for the prime time yet, but it's very exciting. It represents the new trends of checking the new trends of the new biomarker that we never had a few years back. There's similar story for RNA-based, but RNA is very difficult to handle, and so far is pretty much in the research arena only, has not been applied to the general publication, or haven't seen too many publications using RNA-based. How about serum markers? Historically, we've been using alpha-fetoprotein, and I have to say my personal opinion is that there's no one serum markers that will stand out as the only test to use. And there's few ones as listed here. People are doing a lot of research on it, like alpha-fetoprotein L3 and DCP. I have begun to see some alpha-fetoprotein L3 and DCP in the lab tests that ordered by either UCI or some other institution. Can combinations of serum marker be useful? And that's why there's a GALAC score that uses a combination of gender, age, alpha-fetoprotein, L3, and DCP to come up with the scoring system. And this is how the formula is. And in their validation test, the red line is their validation. Compared to all the other single tumor marker, they have a much better predictive values in picking up the presence of HCC. Will this pick up popularity? We do not know. We still need to see a prospective trial to know if this is going to work. So far, In 2020, the only clinically relevant biomarker still the most commonly used alpha-fetoprotein. We use somehow frequently on the screening, but not that much when we come to the diagnosis. Diagnosis pretty much depends a lot of time currently on the CT, MRI, or contrast enhanced ultrasound. We don't use a whole lot of contrast enhanced ultrasound in the United States. And what we use for CT and MRI is called a LIRA. Can that LIRA come to the rescue when we don't have a perfect biomarker? LIRA score can only be used when you have a right background, cirrhosis, chronic hepatitis, or some reason to believe the HCC could be present. When you have LIRA 4 and 5, it's quite suggestive you're dealing with some sort of tumor. And most of the referral that we see right now in the cancer center, many of those come to us because of LIRA score of 5. And LIRA readout by radiology can also be used to follow the treatment response as well. Contrast enhanced ultrasound, supposedly at least one randomized trial from European countries show it could be better than CT and MRI, but it's not commonly used in the United States. On this particular trial, they have a positive predicted value of 98.5%, extremely good. And the reason it's not being used as commonly in the United States is because I think most of the surgeons and medical oncologists do not feel comfortable reading ultrasound, but we actually learn to read CT and MRI quite well. And the other thing is, as far as I know, the contrast enhanced ultrasound has to be done by radiology itself, cannot be done by technician because it's very operator dependent. And hence, I think it's not as commonly used. Most of the clinical trial, when there's a doubt on whether the patient has hepatocellular carcinoma or not, is biopsy. And actually, most of the clinical trial do require a tissue confirmation for correlative study. Now, since the diagnosis supposedly is made, how do we treat HCC? The treatment of HCC should be multidisciplinary, should not be relies on either surgeon, IR, or medical oncology alone. But there are three basic principles. Either we cut, we burn, or we give poison. And my talk today, my presentation today will be mainly focused on the poison. Once upon a time, we have very little way to treat HCC. Some of the older physicians probably remember Dr. Ruperson. It was not until 2007 that we have first tyrosine kinase inhibitor called sorafenib approved. And then there's a long gap of 10 years. Several companies tried several tyrosine kinase inhibitor, never succeeded until regorafenib in 2017. And since then, there's explosions of treatment options for HCC. Every year, there are treatment approved by FDA for HCC to the point where right now we have a lot of options now. How did we get here? Earlier this year, in February 2000 this year, I get a similar presentation on the treatment strategy, and I predict there are going to be a big change sometime this year, and indeed it happened. May 29, we changed the treatment recommendation altogether, and we'll go into this later. How do we get here? From 2007 to 2019, the first line of treatment is dominant by TKI, tyrosine kinase inhibitor. And there are 4 of those available in the market, all approved by FDA: sorafenib, regorafenib, lenvatinib, and cabozantinib. None of those were approved initially for using HCC. They're all approved for other disease. Then the company turned around, tested, checked in the HCC, and find out it actually worked. And so it's kind of more of afterthought after they got FDA approval for something, then they decide to look back at HCC. There are many other TKI failed, but this 4 succeed. And why? How did they work in the HCC? They all have different, none of them were what we call the clean tyrosine kinase. There are all dirty tyrosine kinase, means they have multiple targets they're hitting. And the only consensus or only common target they hit is anti-angiogenesis, vascular endothelial growth factor. And hence, could those benefit all derive from anti-angiogenesis? If that's the case, then we would expect the pure anti-angiogenesis medication to be very effective in HCC. There are three of those available on the market. Bevacizumab, aflibercept, and ramucirumab are considered pure anti-angiogenesis medication. They have no other major mechanism of action. The bevacizumab and aflibercept bind circulating vascular endothelial growth factor. They don't bind to any cell. They bind the hormone in the circulations. Whereas ramucirumab binds extracellular domain of vascular endothelial growth factor 2, is direct attacking endothelial cells. And so it's more direct acting on the proliferating front of endothelial cells. Bevacizumab, this is a drug that has been evaluated extensively, and there's a review article suggests it may have some minimum benefit by itself. On the initial phase 1 trial with sorafenib and bevacizumab was very promising with 12.5%. Back then, we only have sorafenib with a response rate of 7%. So the company jumped very quickly into a randomized phase 2 trial, and it shows, unfortunately, very disappointingly, zero response. And the sorafenib actually has a better survival than the combination arm. So the study was closed prematurely and indicate the bevacizumab may not be a good idea to add to another TKI. Whereas the other anti-angiogenesis medication, aflibercept, never had any human trial in HCC, only has animal model. The other one, ramucirumab, direct acting on the endothelial cells. This is their initial phase 2 trial. As a group, the whole group, the survival was not impressive at all, very similar. The p-value was insignificant. However, when they do the subgroup analysis, they noticed for patient that has alpha-fetoprotein greater than 400, they have an improved overall survival. And the survival difference is quite amazing. It was 3.6 months better. That led the company to do a phase 3 randomized trial, compare only in the patient that has alpha-fetoprotein greater than 400. And this is their final result. The absolute difference is 1.2 months, much smaller benefit than their initial 3.6 months on their phase 2 trial. Disappointing, but FDA approved the medication anyway. So this is really not a true progress in my view, and hence pure anti-angiogenesis doesn't seem to be having a great impact by itself, and hence we began to move on to a combination. Up to 2019, we did make some progress, as you can see on the overall survival. We're reaching 1 year mark, and some of the trial actually suggests it's slightly better than a year. It's much better than what we have, but we're not there yet. Then comes the checkpoint inhibitor. There are two big categories. One is anti-CTLA4 and anti-PD-1 and anti-PD-L1. Anti-CTLA4, based on the antigen presenting cell, which is dendritic cell, supposedly they pick up a tumor neoantigen from the cancer, present to the T cells. But in order for T cell to activate it, the B7 cannot bind to CTLA4. Hence, if we block CTLA4, then the antigen cell or dendritic cell that present the neoantigen from the tumor can activate T cells. Similarly, when there's a neoantigen in the tumor cells recognized by the T cells, it could be positive or negative. If PD-1 binds to the PD-L1, there will be a negative regulation, means T cell will not recognize as foreign, will recognize as self. So you have a monoclonal antibody either against PD-1 or against PD-L1 to prevent the binding, then you have activations of T cells. So the principle behind the checkpoint inhibitor is quite straightforward. All trying to activate T cell, but at different level. One is on the priming phase, the other one on the effector phase. Initial front runner were nivolumab and pembrolizumab. FDA approved those two drugs for second line and beyond treatments in 2017 and 2018 based on single arm trial and has pretty good response rate reported. So it was very exciting. We thought the immunotherapy is coming down to the HCC for sure. And unfortunately, the randomized trial on the first line nivolumab versus sorafenib, on the second line pembrolizumab versus placebo all failed to show a benefit. And this one has not have a full publication yet, but this one published in JCO last year deserve a little bit detailed look in here. The patient that has stable disease were actually quite a lot on the placebo arm. So if you look at the placebo arm with a stable disease greater than 23 weeks, there's about 14.8%. It's no different than pembrolizumab. It argued that for the HCC progression is not always linear, and longer follow-up is probably required to know the true benefit of survival, response rate, etc. And why is that important? Is where we bring us to the combination. Atezolizumab and bevacizumab is anti-PD-L1 and anti-angiogenesis medication. Initial phase 1 data presented in ESMO Asia 2018 has extra high response rate. That's out of this world, 61%, but only 23 patients. By March 2019, on the websites of Roche, the response rate dropped to 32% with more patients enrolled. And then by the November 2019, when they have a third presentation in ESMO Asia, the response rate dropped to 27%. The overall survival at that time was 13.2 months for sorafenib and not reached on the combination arm, but the median follow-up is actually shorter than the overall survival for sorafenib. So very short follow-up interval. The survival data was not updated in January 2020, but they updated the patient-reported outcome is much better on the combination arm. The final data published in New England Journal of Medicine, May of this year, 2 weeks later, FDA approved this combination as a frontline therapy for HCC. And this is the graph from a figure from the New England Journal of Medicine. You can tell the survival here is continuing, but how much would they continue? Is that anybody get cured? We do not know. Again, the median follow-up was 8.6 months, about half of the median survival of sorafenib. And the number of patients at risk toward the end is not that many, hence a few disease recurrence could change the statistic very quickly. And the progression-free survival, the absolute difference is only 2.5 months. It's not that dramatic. But strategically, the company need to push this data out very quickly because there are many competitors. And also, we think there's another reason behind it. This trial used bevacizumab, the real drug, not biosimilar. And the company also probably trying to extend the life of bevacizumab as well. In October this year, the China National Medical Product Administration approved this use in the first lines of HCC, and that potentially could be the biggest market in the whole world. And the challenger really follow very closely behind the genetic application to FDA. This is a combination of pembrolizumab and lenvatinib. They got the breakthrough designation by FDA in July 2019. And they also applied for FDA approval when Genentech was applying for the approval. But they got the rejection by FDA on July 8th because the FDA indicated the result of their trial was not that much different than atezolizumab and bevacizumab. Even though progression-free survival was 8.6 months, better than 6.8 months, but this one has a much longer follow-up duration. The full publication is still pending. Cross-trial comparison is never a good idea, but you can tell that there are other competitors. Both of trial were from China. They all use different immunotherapy drug and also another TKI. And this trial, especially interesting, is biosimilar of bevacizumab with anti-PD-1 inhibitor. And they all presented with a respectable response rate. And this one has a survival data of 20.3 months, also quite promising. So there international competition going on, and we are going to see more of those combination approved by different countries, maybe FDA as well. And eventually, sooner or later, we should have a randomized trial compare different combo to know if one in particular is better than the other. One of the surprises from FDA this year is the dual immunotherapy approval for HCC. It was based on actually a dose finding study. There are 3 arms in this dose finding with different doses of nivolumab and ipilimumab. And the response rate for all three arms were not that much different. However, the survival is the best on the arm A. So FDA, based on this overall survival, approved a dual immunotherapy on the second line and beyond. But it's not compared to anything, even on the three-arm dose-finding study, despite the fact there's no complete response rate in arm C, the 12 months overall survival was 42%, not that bad. It's quite a surprise to medical oncologists that the FDA approved a dual immunotherapy for using HCC beyond first line without a randomized trial, but that's how the FDA worked in 2020. And there is another competitor follow very close behind, also a dual inhibitor. This is their dose finding study, and they picked this dose with week 1 of a anti-CTLA-4 followed by continued maintenance anti-PD-1 with an 18.73 months overall survival to come up with their phase 3 Himalaya trial. And we expect this data to be out sometime next year, 2021. So maybe next year we will have a frontline dual immunotherapy for HCC as well. If 2 drugs is good, how about 3 drugs? So this is a checkmate 040 trial. We don't have a full publication yet. When I checked a few days ago, the combination is either 1 TKI, 2 immunotherapy, or 1 TKI with nivolumab, anti-PD-1. And 2 drug combination, again, overall survival close to 20 months. With 3 drugs, the overall survival has not changed. So is it possible that in the future, the frontline therapy will be a 3-drug combo? Again, we need to wait and see, but it's very exciting. This is a publication in October this year in JAMA Oncology, lists all the, by the date of publication, the available immunotherapy trial in HCC. In my career, I have never seen so many HCC trials available just with the immunotherapy base alone. And it is expected that in the next few years, those trials will become mature and the data will be presented and the treatment field for HCC will change again. The red boxes represent the trial already opened in UCI, and those are only the immunotherapy based. There are few target therapy available as well as not listed here. So this is truly the exciting time for people to get into HCC clinical research, because never before that we had this many trials open internationally. Internationally, also the immune combo is widely used in different diseases, but for HCC, this seems to be the definite trend that we're heading to. But unfortunately, immunotherapy is not for everybody. Probably the most dreadful contraindication is post-solid organ transplant. There are very high rate of graft failure, 81% in less than 30 days if you give them immunotherapy, just 1 dose, and associated death. And this is published in 2019 from MD Anderson, but this is actually the second publication. The previous one in 2018 has a listed similar 81% graft failure rate and death rate. And this 2019 is just they expanded on their available case. Now, there are also some relative contraindication, not absolute contraindication. History of variceal bleed, hepatic encephalopathy, uncontrolled hypertension. Active autoimmune disease is actually debatable issues. There's some data suggests we could activate like lupus, but also there's some data suggests it doesn't affect the disease activity of lupus. So unfortunately, we don't have randomized trial, only case reports. It's still continue to be controversial. And the other category is patient being evaluated for possible liver transplant. I could not find much of a data to say that immunotherapy given before liver transplant would affect the graft acceptance, but most of the liver transplant centers prefer that we don't put patient on immunotherapy. Before TKI, the HCC survival was horrible. From 2007 to 2019, we see progress. In 2020, we are hitting somewhere around 20 months of overall survival for advanced HCC. For the future, I'm hoping we can reach 30 months or beyond, sometime in the near future, but that's the hope. For conclusion, there are way too many possibilities in 2020 for medical oncologists. We now have so many different drugs, different combination, immunotherapy, or immunotherapy combo with different things. It's very difficult to decide who should get the first line of what. Single agent TKI is still being used, but not as commonly. The FDA approved are mainly, unfortunately, for child A, but to be honest, we use a lot of off-label use for child B and C. As long as patients willing to accept the risk, we could adjust the dose and still treat the patient with child B and C hepatitis, child B and C these conditions. There are so many active clinical research with new drug, and the future is bright for us. Traditional cytotoxic chemotherapy is really fading into historical interest, and I don't think there is much chance it will get resurrected right now. And the treatment is truly changing rapidly. So what I presented today, it may change by 2021. In November this year, Mayo Clinic come up with the proposed algorithm. The patient with the first-line advanced HCC, if they have no contraindication, they should all get atezolizumab and bevacizumab. If they have contraindication, then can consider sorafenib or lenvatinib. The patient on the second line then depends on your alpha-fetoproteins. But the question is, if somebody has seen atezolizumab, would that respond to second-line immunotherapy? And we have no data on that. Or should we give them the break with the TKI followed by third-line immunotherapy? We don't have data. And how to sequence the other TKI, we also don't know. So there are, in addition to the frontline research with the immunotherapy combo, there are many trials looking at what is the best sequential therapy for HCC. And we have many patients in our clinic is going into fourth line, fifth line treatment for HCC that's never heard of before. So the future is bright. Any questions?